Hi, I'm Dr. Michael Polin. I am a urogynecologist here at UT Medical Center, and we appreciate you joining us today. We're going to talk about the UT Center for Pelvic Health, and with me I have Dr. Lacy. I'll let him introduce himself.
Hi, I'm Dr. John Lacy. I'm with University Urology here at UT Medical Center. I'm a reconstructive urologist.
And Dr. Lacy and I work together regularly as part of the Center for Pelvic Health here at UT Medical Center, and that is a center that brings together multiple subspecialists within the group here at UT Medical Center, and that includes urogynecologists like myself, and we are kind of a hybridization of female urology and gynecology, and take care of issues specific to what we refer to as the pelvic floor, and a lot of that deals with pelvic or vaginal support issues, what is referred to as pelvic organ prolapse, as well as urinary incontinence. And I work some with fecal incontinence as well, and then that also includes people like Dr. Lacy with urology, and I'll let him describe what he does specifically. But beyond people like Dr. Lacy and I, it also includes colorectal surgeons who do a lot of work with fecal incontinence as well as other colorectal issues, as well as general gynecologists and pelvic floor physical therapists and physicians that work or specialize in integrative medicine. And so, Dr. Lacy, if you want to tell us a little bit about what specifically you do in terms of reconstructive urology.
Absolutely. So, as a urologist, we deal with the upper and lower urinary tract for both males and females, and then the female urinary tract. So, for the purposes of this talk, we certainly deal with male and female urinary incontinence or lower urinary tract symptoms like urinary urgency, frequency, weak force of urinary stream. Sometimes you may develop scar tissue within the urethra and be unable to completely empty the bladder. Sometimes there could be nerve damage to the bladder or some other impediment to the bladder fully emptying. And so we sort of would see the patient and evaluate which symptoms are most bothersome or most detrimental to your health or quality of life, and then develop a plan for either further testing to evaluate and pinpoint that exact issue, and or trials of either physical therapy or behavioral changes to what you eat and drink or your exercise regimen. There's also, we could design a regimen of medication trials or even surgical procedures depending on what's necessary.
I think you bring up several great points, Dr. Lacy, and that's when we talk about the pelvic floor and medical issues related to the pelvic floor. I think the important thing, at least from my aspect in the patients I take care of, is we really take care of quality of life issues. And there's a whole spectrum of treatment options available for bowel and bladder control issues and vaginal support issues that range from more conservative therapies of pelvic floor physical therapy and lifestyle modifications to medications to surgery. And so it's kind of how aggressive or invasive the patient wants to get to improve their quality of life with a lot of these issues. To expand a little bit more on what you said, kind of my background within urogynecology is that my residency training was at University of Alabama at Birmingham, and it was in obstetrics and gynecology. And then I went on and did a fellowship beyond that in female pelvic medicine and reconstructive surgery, or what we refer to more generically as urogynecology, and that was at Duke University. And so that's where that hybridization of urology and gynecology come together for me. And I know you've done some additional subspecialty training as well within urology.
Absolutely. So I did my residency at University of Kentucky in general urology, and then did a fellowship at the Cleveland Clinic in Cleveland, Ohio, in reconstructive urology and prosthetics. And that's what ultimately drew me here to Knoxville. I have family both in Kentucky and Georgia, so it's kind of right in the middle. And that's where we started the search geographically. But the more we looked into it, this is an excellent medical center, and there was a real need for reconstructive urology. There's no one fellowship trained in the area, and so it just set up nicely to set up my practice. That's what drew me here in the first place.
Yeah. The nice thing about UT Medical Center being such an academic institution is we are able to get these different types of subspecialists together for this type of center, and the Center for Pelvic Health is very unique to UT Medical Center in East Tennessee here, and Because of that, I know we try to access or provide easy access for patients to get in and see us, and so there's a number of satellite centers or regional health centers that we go to. I know I personally go to the Regional Health Center in Sevierville as well as the Regional Health Center. Both of those are UT Medical Center in Lenore City. And then beyond that, I'm here at UT Medical Center, and then also the UT Medical Center clinics in Turkey Creek. And I know you go a number of places as well.
I do. As you said, I personally go to the Regional Health Center in Lenore City, and I have a satellite office in Crossville as well. But my partners go to the Regional Health Center in Sevierville, the Medical Plaza in Turkey Creek, and then also satellite offices in Athens, La Follette, Halls, Clinton. So we really try to have these outreach areas to make it easiest on the patients. So if you're not coming for surgery or a specific test that's only offered at UT, it's more convenient to come to those outlying locations. That being said, it's nice to have the resources and the shared information that we do with the Center for Pelvic Medicine and the collaboration between all these different specialties. It's nice to have those kind of amenities without having to drive all the way to Knoxville every time.
Absolutely. And I know sometimes patients aren't sure the best way to access us, and that's the nice thing about the Center for Pelvic Health is you can just contact the center itself, and that can be accomplished through University of Tennessee Medical Center's website. And then also with this Facebook live posting, they'll have the phone number for the center itself, and patients can directly call that phone number and then go through a questionnaire with one of the staff or the providers, and that helps to distribute them into the correct subspecialists that they need to see for their problem. You have anything else to add at this point that we haven't covered?
I was just kind of thinking it might be reasonable to go over a couple of common clinical scenarios that we see. So when someone comes in a lot of times to the urology office and they say, I'm leaking urine, that can go in a couple different directions. And one of my first things to do is just educate people on different types of urinary incontinence. And I basically break it down into stress urinary incontinence and urge urinary incontinence. So stress urinary incontinence would be typically leakage of urine when you sneeze, cough, bend over, lift something, anything that puts stress on the abdominal wall and that force is applied to the bladder, and you don't have the sphincter tone or pelvic support to hold on to that urine. Urge incontinence, on the other hand, is more of a storage of urine issue. So the bladder is not storing the urine at a low enough pressure and giving you plenty of time and heads up to get to the restroom and to void. So we kind of try to break that down first, because that greatly affects the different treatment options available. From there, once again, we would devise some additional questions or testing, because those two treatment strategies would be radically different. Anything from pelvic floor physical therapy, or even surgery like bulking agents or slings or other pelvic surgery for stress incontinence, as opposed to medication trials, percutaneous tibial nerve stimulation, Botox injections into the bladder, or even basically a pacemaker for the bladder for the urge incontinence. So totally different pathways. Would you agree?
Absolutely. I see a lot of those issues as well. We shared some of those patients, and beyond that, from the vaginal support standpoint, I take care of a lot of what we call pelvic organ prolapse, or I see patients who have essentially a bulge or protrusion from the vaginal area, what people kind of classically refer to as that drop bladder. And that can be a complex issue that is not necessarily a cause and effect relationship in terms of that bulge or protrusion, urinary incontinence, but common things that occur together. And so we have a pretty comprehensive approach to address those support or prolapse issues that range, like you say, from more conservative therapies with physical therapy to devices that fit inside the vagina to provide support to the pelvic organs, to surgeries that reconstruct the support of the vaginal walls. And those things can be accomplished with and without mesh materials, as there's some stigma related to mesh at times, but there's approaches both ways. And I think beyond the more straightforward things that you mentioned and I've discussed, you and I specifically have worked together in taking care of patients who've had care and had complications from some of the treatments of these, and we've been able to work through those issues with them.
Absolutely.
And it looks like we have a question that's come in here. How will I know what type of physician to see at your center?
So I think that's where the center really comes in, and by just calling the number that'll be posted for the Pelvic Health Center, we have a questionnaire that we work through when a patient calls to help kind of understand their symptoms so that we can get them in with the right provider from the beginning and kind of streamline their care to address their issues.
And I'll say both of us have had patients that have come to see the other first, and we've said either, can you just take a look at this person and they have a second opinion, or I think this person would be better suited for you, and it's truly a collaborative effort. There's
Absolutely.
no, we're on the same team just trying to help patients the best we can.
Absolutely. Any other questions?
Thank you. That was it. Thank you.
Well, if there aren't any other questions out there, unless you have something to add, we could kind of wrap this up.
I think I was going to say, maybe another very frequent scenario we see is recurrent urinary tract infections.
That's a good point. That's common.
Sometimes, we kind of classify that as 3 or more urinary tract infections in a year. We like to get some more information and get urine cultures to see if those are truly bacterial infections and kind of correlate those with the symptoms. But you want to talk a little bit about different strategies for preventing urinary tract infections?
Yeah, so obviously they're not an uncommon thing, and at least from the female standpoint, become more common as women get older and go through menopause. And for women who are frequently getting infections, we can do things as simple as get them on vaginal estrogen cream to improve the vaginal tissue health, which can help reduce UTI risk, to in more aggressive scenarios, getting them on preventative antibiotics that they take on a regular basis to help minimize their infections. And something we haven't talked about, you and I focusing a little bit more on bladder control issues and vaginal support issues. Fecal incontinence is another common problem, and something that patients really don't like to talk about because it's pretty embarrassing and carries a lot of stigma with it, but it is not all that uncommon of a problem, and there's a lot of treatment options available. And that can result in pretty significant improvement in symptoms and quality of life. All right. Well, it's been a pleasure speaking with you today, and we appreciate you all joining us. And we'll wrap it up with that.